Ma'am, I have shared the PPT with you and Hitav on WhatsApp and with you on email also.
Yeah, I have sent it.
We'll wait for 5 more minutes.
I think we are
10,
good to
5.
go. Okay, no problem. Asmita, I shared PPT with you. Did you receive it, please?
Yes, ma'am, it's received.
Thank you. Radha, don't worry, we will share screen. You can log in from one device only, otherwise there will be a lot of echo.
Okay, ma'am.
Huh? We are good to go, sir. Abhishek sir, Surya sir.
If some more people join, 10, 5, you can start.
Okay, sir.
You can start. So now we can start the program.
Yes, sir.
Welcome, friends. On this occasion of World Physical Therapy Day, IFNR has created a very special webinar on a very common but unspoken topic of low back pain. I think all of us suffer low back pain anytime in our lives. Today, with the esteemed panel, we'll discuss how we can help with conservative management for patient with low back pain. The dialysis supervisor, please take it forward.
Asmita, can you share screen? Can you go to chairperson screen, chairperson slide? Very good morning all. On this account of World Physiotherapy Day, IFNR has taken an initiative to recognize the contribution of the members of rehabilitation team, that is physiotherapists, who are working extensively in patients with neurological dysfunction. And I wholeheartedly thank Dr. Nirmal Surya sir for taking this initiative and inviting the panelists or inviting the speakers for this particular session from the fraternity of physiotherapy. And the chairpersons for today's sessions are Dr. Abhishek Srivastava sir, Dr. Abhishek Srivastava. He is associated with neurorehabilitation unit or Center of Neurorehabilitation at Kokilaben Hospital, Mumbai, and with the basic qualification of MBBS, MD, DNB, and PhD. He has a lot of achievements on his name, which primarily includes Dr. Anisya Vasant Award, the Dichi Award, and Professor Navendra Kumar Mathur Award. And he has been in association with many of the associations in different capacities. And he has published 2 books, 15 book chapters, and 80 research papers. And with his extensive experience in the field of neurorehabilitation, we have been looking at him as one of the guiding stars. Thank you so much, Dr. Abhishek Srivastava sir, for joining us as the chairperson. And myself, Dr. Suvarna Ganvir, I am another chairperson for today's session. And I have been associated with the Indian Federation of Neurorehabilitation as the task force member and the member of World Rehabilitation Alliance Primary Care Group. And I am greatly indebted for Dr. Nirmal Surya sir for giving us, the physiotherapists, an opportunity to be a part of IFNR. And we are working towards making the IFNR and the neurorehabilitation the most successful one. Thank you all so much. Moving on to today's session. The first session is by Dr. Jui. Dr. Jui is the professor and head member of BOS MUHS Department of Neurophysiotherapy, Terna Physiotherapy College, Navi Mumbai, with the qualification of BSc Physiotherapy and MSc Physiotherapy. She has achievements in her name as the teaching technology workshop done at Mysore under TOT program by RGHS in 2002, advanced teaching technology program by MUHS in 2010, and research methodology program in 2008, and research methodology program by MUHS in 2015. Welcome, Dr. Jui, for the session, and you may.
Ma'am, sir, hello. Sorry, ma'am. Ma'am, we'll have
Sure.
Dr. Nirmal Surya say a few words because then sir is getting busy with the meeting. So he'll
Okay.
just start with his opening remarks and he'll go, ma'am.
Yes, sir,
Yeah.
please. I'm sorry, sir. I missed it.
Never mind. Mistakes always happen. And that's why when you are doing the mistake in sitting, you get the back pain. So I'm here at Gandhinagar IIT. So I'm actually come here for a collaboration with IFNR about us. So I greetings comes from IFNR, of course, and I bring also greeting from the Asian Oceanian Society of Neuro Rehabilitation, as well as from the World Federation of Neuro Rehabilitation in the capacity of President and Secretary General of WFNR. So today being a very important day, as you all are involved with the therapy, and I want to wish the best wishes on the occasion of World Physiotherapy Day. Uh, and the theme for this year is backache prevention, management, and which is very important because as we use or misuse our body by not being sitting properly or sleeping properly or working properly, the back and neck pain are something which keeps on happening. Uh, I remember that when you have a severe back pain, you are incapacitated and you are bedridden. You either go to a orthopedic surgeon or you go to the neurosurgeon or the neurologist, and you either are offered surgery or the next option is physiotherapist. Now, 90% or 80% of the back pain are related to the muscle spasm and misuse of our sitting posture or lying posture. Most of the time we sit in sofa or in the chair which are not appropriate to support our back. And many people who are obese develop the muscle weakness, large abdomen, they become the posture change. So I'm sure all these things are will be discussed today in the webinar. But what I'm trying to tell you is that physiotherapy is so important. A good physiotherapist with expertise in mobilization can even cure a disc which is compressing on the nerve and causing a person incapacitated even to turn in the bed. I remember even 25 years ago during 90s when we used to treat the acute back pain, uh, with surgery. But one of my uh, good friend and teacher, Mr. Chabaria, used to treat this patient conservatively. And I remember large disc being treated under our care with the help of good physiotherapy in period of 3 to 6 weeks. Of course, you need time, but you can still a good physiotherapist can make you back to the normal life without even a surgery. So the therapists, if they are good, they can challenge a neurosurgeons and they can challenge a good spine surgeon. So these are the things which are going to be discussed. I think it is very important that we learn about how to manage our back, how to sit in the chair, how to use our mobile while sitting or eating and day-to-day habits. And all of them will teach you today about all those things. And who are the patients who should go for surgery, what you should be doing when you have this thing. So my best wishes to all the speakers. The speakers are all learned one and expert in their field, be it Abhishek or be it Swati or Radha, or all of them are expert, and I am sure they will bring you the best of knowledge. I, from my side, wish you all the best, and I'm hoping to learn some good tips because I always also get back pain while sitting for 8 to 10 hours a day on the chair and working. So we really need tips from you how to keep ourselves fit in the posture. Thank you very much for asking me to speak, Suvarna and Abhishek. I wish you all the best.
Thank you, sir.
Thank you, sir. Learning is two-way. We learn lot of things from you. So thank you so much. It's our pleasure and it's our honor to be a part of IFNR, sir. Thank you so much for giving us this opportunity. Over to Dr. Jui, please.
All the best.
Thank you, sir.
Thank you, sir. Thank you. Thank you, Dr. Surya, for that very, very motivational words. And I am actually very grateful to the IFNR, Dr. Surya, Dr. Abhishek Srivastav, and Dr. Suvarna Ganveer for inviting me and making me a part of this panel. Uh, as Dr. Surya has very correctly said that back is one of the most under reported, or rather under estimated part of our human body, which often gives you maximum trouble, and the quality of life declines with this kind of low back pain. Next slide, please. Can I have the next slide? Yeah, thank you. So as we are celebrating the World Physical Therapy Day today, as proposed by the WCPT, the topic for this year's World Physical Therapy Day is a low back pain, which is turning into a global epidemic. Now, these are very strong words, and it indeed has become a global epidemic from a physiotherapist perspective, because the number of patients that we see per day of low back pain patients are exponentially increasing, and that is very worrisome because majority of them are preventable in nature. So, what we are going to try and understand is the pain patterns and how do you manage the pain pattern. From my side, I'm going to be talking about the types of pain that we encounter, especially in neurological conditions. So, next slide, please. So, it's very, very evident that low back pain is a very disabling and costly condition. Costly in the sense that it costs you not just financially, it also costs you your functional independence. It costs you your quality of life. There are a lot of things that you give up in order to protect your back and in order to prevent the pain. So it's basically the most common cause of years lived with disability and the sixth leading cause of disability adjusted life years. And there was a systematic analysis that was done. So it has chronic low back pain has been a leading cause among 354 diseases for years lived with disability. Next slide. So when we go to low back pain, the anatomical definition or the strict boundaries for low back pain that we draw are the pain that originates below the costal margins and above the inferior gluteal folds with or without referred leg pain. Okay. Now, this is the textbook definition of what is considered as low back pain. Next slide, please. But if you consider the origin of low back pain, we need to understand that low back pain is not restricted to the pain originating from the lower back structures, which is a very common perception that most of us have. Pain and nervous system have a very close relationship, and it is not just the nociceptors. If you understand the chronicity of pain, we will also appreciate the fact that you have changes at the perceptual level, the perception of pain, the cognition of pain, and the fear avoidance mechanisms that come with the chronic low back pain. And this is very, very commonly seen in case of low back pain patients. And whether you call it kinesiophobia, whether you call it fear avoidance behaviors, whether you call it, being very, very sensitized to even a trivial amount of pain, nervous system and pain are just more interestingly correlated with each other than just the stimulation of nociceptors. Next slide. Yes. Now, when we talk about low back pain in neurological patients, we can look at it from two perspectives. One perspective is the presence of low back pain due to altered biomechanics in case of, major neurological conditions. And the second one is the low back pain originating by the involvement of neural structures that results in various pain patterns, that results in low back pain being radiated to both the extremities or radiated to the internal parts of viscera, giving rise to very complex pain patterns. Next slide. So, as I said earlier, despite pain sharing a very close relationship with the nervous system, disorders of low back pain giving rise to neuropathic pain patterns are generally ignored in terms of differential diagnosis or in terms of management. Next slide. if we consider the classification of low back pain patterns in 2021, the International Association for Study of Pain had proposed the clinical criteria, and they classified patients in three categories. Next slide. The first category that is seen is the nociceptive. The second category is nociplastic, and third one being neuropathic. Next slide. So if we understand a little bit more about this classification of back pain, the nociceptive back pain is your classical back pain resulting from trauma in terms of altered biomechanics, in terms of degenerative disorders. So basically activation of nociceptors that innervate the structures in and around the low back, which is your ligaments, your joints, muscles, fascia, tendons, and that is basically as a response to a tissue injury, which is leading to inflammation and stress, giving rise to your classical back pain pattern. The next category that they have described is the presence of neuropathic back pain. Now, neuropathic back pain is basically pain that is arising from the injury to nerve roots or the neural structures in and around the back pain. Okay, so basically, you're going to have radiating pain patterns, which basically comes from the affection of nerve roots that innervate the spine and the lower limbs. The last category that they have given is a nociplastic back pain. Nociplastic back pain was also earlier referred to as a central sensitization patterns. So the pain that arising from the altered nociception. So there may not be any clear evidence of a tissue injury or a nociceptive injury or a neuropathic injury, but you still have a vague referred pain in and around the low back pain structures. So what we are going to be doing is very briefly and superficially try and see the pain patterns involving all these three categories.
Next.
Yeah. So the nociceptive pain patterns are in terms of pain location. The nociceptive pain is very clearly localized to the area of injury. The patient is able to pinpoint towards a particular area that this is where it hurts me. Sometimes it may extend up to the legs. The pain is usually characterized as a sharp, aching, or a throbbing pain confined to an area. You are going to have very clear aggravating and relieving factors, which means there will be a particular movement which aggravates your pain, and there will be a particular posture or a movement that is going to relieve your pain. Okay, so basically, nociceptive pain is caused by damage to a non-neural tissue. You can call it as a muscle sprain, muscle strain, trauma. So these become your classic low back pain, nociceptive pain patterns. Next slide. Yeah. So when you go to neuropathic pain patterns, so which could be because of a nerve compression, which could be because of a nerve root compression, maybe because of an herniated disc, disorders like sciatica. So inflammation of the nerve fibers, degeneration of nerve fibers. The pain character is usually burning, electric shock like shooting, stabbing, and sharp. Usually how the patients describe as ants crawling or any other unpleasant sensations. Pain is usually felt in the low back, upper buttocks, coccyx, groin, and radiate to the lower limbs. Okay, and neuropathic pain patterns have a very classic combination of other neurological factors, which could be sensory loss, which could be motor loss, motor weakness, or which could be because of absence of reflexes. So these usually form the neuropathic pain patterns. Next slide. Can I have the next slide, please? Okay. No, the previous one. Yeah. So we go to the third category.
The nociplastic pain pattern.
Now, nociplastic pain patterns, as I said earlier, are a kind of vague origin, chronic low back pain, which is mixed with neuropathic pain caused by changes in how the nervous system processes pain. Okay. And which is why it's also considered as a part of non specific low back pain, where the patient is unable to identify a particular area, unable to give you any specific traumatic history or anything that makes your diagnosis very narrow. Uh, Nociplastic pain can have a sudden onset, very difficult to identify the exact location of pain, which is vague and referred. It is constant and unremitting, which means that there are no identifiable aggravating or relieving factors, and it can be unresponsive to traditional treatments. So it may be associated with fatigue, depression, anxiety, disrupted sleep. So a combination of all these symptoms together with non-specific back pain usually classifies the back pain in the nociplastic pain pattern. So basically, it's an amplification of the pain response by the central nervous system. So next slide, please. So usually when you see a low back pain patient, you may have uh, an individual or a combination of all these three forms together, which are going to give you a very different and a complicated pain pattern, which are going to require a lot of differential diagnosis and management. Next slide. So in a very, very simplified perspective, you can also categorize them into acute and chronic low back pain, which I'm sure everybody is familiar with. The last slide. So the take-home message, as far as today's talk is concerned, is in terms of understanding what produces low back pain and also understanding into realizing that low back pain management or pain patterns are not usually confined to the trauma of structures in and around low back pain, but we can also have pain which can be modifiable at the central level. So thank you very much.
Thank you, Dr. Joy, for that very simplified presentation. And yes, low back pain in neurological conditions makes the impairments double-fold. To have a look at another perspective of low back pain, I invite Dr. Swati.
Yes, good morning, ma'am.
Good morning. Ms. Asmita, can we have a slide?
Ma'am, I will share.
No, introductory slide. So we have Dr. Swati Bise with us, who is going to speak on physiotherapy approaches to low back pain. Dr. Swati is the principal and professor at School of Physiotherapy, Bharati Vidyapeeth, deemed to be University, Pune, and she has various achievements in her name. The list is quite long enough. So, and probably she needs not much introduction in the field of physiotherapy. So, moving on to her talk, which is physiotherapy approaches in low back pain for the prevention of low back pain, specifically with respect to the neurological conditions. Over to Dr. Swati, please.
Thank you, Suvarna Ganvir ma'am. Thank you, Nirmal Surya sir, and thank you, Abhishek Srivastav sir, for making me a part of this webinar. It's a privilege to present on this occasion, special occasion. So today's my talk is physiotherapy approaches for prevention of low back pain in neurological condition. As Zui ma'am has made my job little bit easier because in neurological cases, okay, we'll start. First one is this is the content of this is flow of content which I will be dealing with the introduction, prevalence and prevention and references. As Zui ma'am has given a guideline regarding the pathophysiology, the majorly in the neurological cases, it is related to the posture and biomechanical alterations. And again, the central processing system, which is affected, due to which the low back pain is generally seen in the neurological cases. Low back pain is a public and occupational health problem that is major professional, economic, and social burden. It is up to 84% of the general population will experience during its lifestyle. And again, the recurrence rate is more high. If we see the prevalence of low back pain, it majorly seen in the Parkinson's patient, then relatively in the multiple sclerosis, and even in the spinal cord disorder is depend on the level of lesion, it depend on the complete or incomplete type of injury. But the prevalence on the stroke is still in need to be studied because it's not found in the literature. And again, what is mentioned, the prevalence of low back pain is majorly found in the person who was taking care of the stroke patients. So these are the different approaches through which we can make aware about the patient regarding the low back pain. So first one is education regarding the causes of low back pain and also a pain management. And we do provide a home recommendation program to the therapy, to the patients. We recommend it for the regular exercises, walking especially. We also recommend to them maintain them a good posture, active health, active lifestyle, and again, we provide them a ergonomic guideline regarding the transfer, regarding their workstations, and regarding different exercise and the lifestyle modifications. One-to-one education on biophysiological contribution to the pain, that is self-management techniques such as we ask them to remain active throughout the life, take the spacing strategies, and also give a back protection techniques. We also provide a guideline to the caregivers regarding the patient safety, positioning, transferring, and different handling ways to make sure that the patient is handled carefully. So physiotherapy exercise remains an first line of treatment for prevention of low back pain. So in acute and later stage of disease, we generally deal with the reducing the pain and disability through the trunk muscle activation. We recommend for avoid the prolonged static position, and also avoid a strain on the lumbar spine during the positioning static and as well as in dynamic. Bed mobility and transfer should be facilitated without causing strain on the back. Static core exercises are advisable, and early mobilization is always encouraged, and active strategies should be encouraged whenever and wherever possible. So these are there are many in the exercise based interventions are available, but few of them I would like to share with you. So first one is motor control plays an important and critical role in stabilizing the spine. Basically it works on the three systems. One is the passive, where the ligament and fascia plays an important role. Second is active contribution through the core muscle, which helpful for maintaining the spine movement as well as the stability of the spine. And the central nervous system, which work for the motor control. So through central nervous system, there is a physical action and the prevention, and it also help in prevention to maintain the stability as well as mobility of the spine. As a physiotherapist, we can encourage this motor control through different neuromuscular re-education, biofeedback machines, and even through a functional electrical stimulation. In spinal cord injury, what the Yuan Bang et al. Said that in cervical spinal cord injury, there is a higher incidence of lumbar spondylosis, and that is due to the previous minor trauma, and also degenerative changes causes a low back pain. The muscle weakness and the impaired proprioception leads to the poor posture such as kyphosis and hyperlordosis, so which leads to weakness in the core muscle, which indirectly affect the spinal stability, and that causes a low back pain. Again, in one study, when Dion has mentioned about, he has done a review regarding the core strengthening protocol for the low back pain in the patients with the low back pain. So where he has compared the control group with a different experimental group. The experimental group is considered of motor control exercises, stabilization exercises, segmental stabilization exercises, and trunk balance exercises. So what he concluded that it is important to use the strengthening exercises to improve and increase the endurance of the core muscle. Lumbar stabilization exercise with general rehabilitation is significantly important in the treatment of the low back pain patients. Also, in multiple sclerosis, lumbar spasticity plays an important role to creating a back pain, asymmetrical posture, difficulty in ambulation, and also it is seen that female patients have a more prevalence of low back pain than compared to the male patient. Generally, it is seen in the later stage of diseases, and also the how much if the disease is longer in the duration, so automatically the patient have a low back pain symptoms. Again, the author has shared many different physiotherapy approaches for treating the low back pain in the multiple sclerosis patient, which include manual therapy, kinesiotherapy, and electrotherapy. Okay. These are the these are the techniques which are effective for treating the low back pain. Then flexibility training is one of the major aspects where the restrictions within the musculoskeletal system causes disorder in the muscle synergy, consequently increase in cost of increasing the energy expenditure. So stretching exercises are recommended for improving the mobility and reducing the pain. Then again, Jacob et al., what he have done, he has compared the low back pain and Parkinson's symptoms. There is a coexistence found. He found a coexisting between the symptoms of low back pain and Parkinson's, where there is altered corticostrial structure and the function. The automatic postural responses are affected in both groups due to stiffening of the muscle contraction. There is a impaired somatosensory acuity, and there is a slowness in the walking, rigidity to the posture movement, and anticipatory postural adjustments are delayed. So what he had added, the axial and spine segmental rigidity, excessive axial and postural tone and stiffness that is majorly seen in the Parkinson's patient. So whenever we are dealing with the patient for the low back pain, so the approach has to be first line of treatment is reduction of pain, improving the strength, and maintain the flexibility. No clear-cut guideline has been given for specifically related to the neurological condition. Second, what he concluded that whenever we are dealing with any low back pain patient, make sure that we are looking after or addressing the postural control impairments also. So PNF also is one of the proprioceptive neuromuscular facilitation is one of the approach through which it is can be used in combination with the physiotherapy, which will be helpful for decreasing the pain intensity. Also reduces the functional disability and increase the lumbar spine range of motion. Too commonly, the rhythmic stabilization training and combination of isotonic exercises are frequently being used. Okay, walking is proven as a best resource for for reducing the pain, disability, and enhances the quality of life, and even it reduces the fear of abundance. Walking is an alternative and again cost effective. And walking with functional training is also help to additionally it helps to reduce the degree of pelvic anterior tilt. Advanced technology, VR has shown a significant effect on reducing the pain intensity and kinesiophobia. The author has done a systematic review and meta-analysis on different approaches of VR versus physiotherapy, VR plus physiotherapy versus only physiotherapy, VR physiotherapy versus VR exercise plus physiotherapy. What he has proven that the effect of VR in combination with physiotherapy has given a significant improvement in reducing the pain intensity and kinesiophobia in patient with a low back pain. But in neurological patient, the study is not much available. There are different approaches like Pilates, which can be helpful for maintaining the stability of the spine, by improving the motor control in the deep muscles, and even by reducing the activity of the superficial muscle, which directly works to improve the posture and body awareness. Then other different approaches that has to be in conjunction with the standard physiotherapy protocols, the neurodynamic mobilization and mobilization, again soft tissue therapy, and again trigger point therapy, which can be helpful to reduce the pain as well as to improve the range of motion in the low back pain individuals. There are different approaches like aerobic exercises, effect of yoga, tai chi, aquatherapy, and cognitive behavior therapy. This is also useful for reducing the back pain, but that has to be in combination with standard physiotherapy treatments. There are different assistive and adaptive equipments which can help to reduce the physical demands on the low back pain in neurological conditions, can be helpful. Then again, there are different modalities and assisted aid by Martina. What he said, that the few modalities are not recommended in neurological conditions while treating a patient with a low back pain. Then as a therapist, we generally deal with the exercise, and exercise adherence is one of the major factor when we do advise the patient a home exercise program. That again, we now the telerehabilitation is one of the important, and we generally give them a progressive training. So telerehabilitation can be given through smartphones, telemonitoring, mobile apps, and the patient caregivers and medical professional has to be trained for all these kind of devices. Then the last one is lifestyle modification plays an important role in prevention. The encourage healthy lifestyle, which include a plant-based diet, sustainable physical activity. We recommend for the mind-body exercises, restorative sleep activity, then stress resiliency, awareness about the substance abuse and addiction, and we encourage for establishing a meaningful social network and self-care strategies. So use of active multidisciplinary rehabilitation should focus on self-management and healthy lifestyle, and can assist return to the work in chronic low back patient. So final, the goal of physiotherapy in preventing the low back pain was specifically related to low neurological patient. Physiotherapists do deal with the exercise-based intervention, which directly help to improve the mobility of the spine as well as maintaining the stability of the spine, which indirectly help to improve the quality of life by reducing the risk of low back pain and energy expenditure. So it is important to implement properly planned physiotherapy activities and educate the patient how to combat with the lumbar spine pain. So these are my references. Thank you.
Thank you, Dr. Swati.
Thank you, ma'am.
As an overview of what are the physiotherapy approaches that are available for the low back pain. So it is important for a neurophysiotherapist to understand as to what kind of low back pain is there, and probably we need to refer the patient to a specialist in our counterpart, that is the musculoskeletal physiotherapist, as and when required. So thank you so much,
Yes,
Dr.
thank you,
Swati, for the lucid presentation.
Yes, thank you, ma'am.
Taking the discussion ahead, let's look at the interdisciplinary approaches that can be used for treating the patients with low back pain in neurological conditions. And for that, I invite Dr. Radha Bhattar. She is the Vice Principal and Professor and Head at the Sancheti Institute of Physiotherapy, Pune. And she has been awarded Significant Contribution Award at 9th International Conference of Physical Therapy at AIIMS, and Professor Manik Shahani Senior Platform Presentation Award at 8th SIPCON at Chandigarh. And she has a lot of credentials on her name. So with this, I invite Dr. Radha to start with her presentation, please.
Good morning, everyone. I am really thankful to IFNR, Nirmal sir, Abhishek sir, Ganveer madam, and Hita for giving me this opportunity to be present here on the occasion of World Physiotherapy Day.
and speak about management of low back pain in neurological patient. I hope my job has been made very easy by Juhi ma'am and Swati ma'am. More or less, the content that I'll be covering in my presentation is what are the common neurological conditions in which we can see low back pain, factors that lead to low back pain in neurological patient, assessment of low back pain in neurological patients, as well as pain management techniques in the neurological patients. So coming to the common neurological condition, already as mentioned by Swati ma'am, the most prevalent conditions are multiple sclerosis, Parkinson's, and spinal cord injuries, followed by many more like herniated disc, which leads to neurological impairment, stroke not been yet studied much, cerebral palsy, especially in the chronic stages, adult cerebral palsy patients, multiple sclerosis patients, especially the ALS patients, they do experience back pain. So these are the common neurological conditions in which we often get to see patients having low back pain. Coming to the next slide. What are the factors that leads to the low back pain in the neurological patients? The most important is the altered biomechanics and the compensatory movements that they repeatedly do to compensate for their activities of daily living. Spasticity has a good contribution into it. Postural abnormalities, muscle imbalance, gait abnormalities, impaired motor control and coordination, muscle weakness. There are many more psychological factors which the literature suggests needs to be tackled. Fatigue is one of the factor which leads to low back pain in them, and prolonged sitting or immobility, as already mentioned by Swati ma'am, that early mobilization or early movements become very necessary for them. So prolonged sitting and immobility plus reduced mobility and the flexibility, these are the factors that leads to low back pain in neurological conditions, and they need to be tackled in a multidisciplinary approach. I'll be just speaking more towards, a bit of physiotherapy as well as multidisciplinary approach. Moving towards what all we'll be doing in the assessment of low back pain in a neurological patients. So neurological condition evaluation, what the patient is suffering through, what is the tone level, what are the postural abnormalities, pain characteristics is what already as mentioned by Juhi ma'am about the pain characteristics that we have. So we need to know the nature of pain. It's neurogenic, neuropathic, what kind of pain, location of pain, aggravating, relieving factors for the pain, plus functional assessment. What is the impact of this pain on the quality of life of a patient? So this all are the points that we need to cover in the assessment of low back pain in the neurological patients. Next slide. So when we are moving towards the pain management, we have different approaches. So manual therapy, electrotherapy, postural and ergonomics modification, exercise prescription, neuromodulation techniques, multidisciplinary approach, patient education. These are the main focus areas that needs to be tackled while dealing with the low back pain. If we see major causes musculoskeletal and neurological thing, so definitely we need to have musculoskeletal physiotherapy approach also towards it, as well as neurological approach towards it. Plus, when we move towards the multidisciplinary approach, the team should be comprising of neurophysician, orthopedic surgeon, orthopedicians, as well as psychologists and pain management personnels like anesthetists and, if required, so on others also in the team for tackling with the patients. Next slide, please. So if we deal with the manual therapy, what all that can be used is soft tissue mobilization and joint mobilization. Soft tissue mobilization, we have facial manipulations, myofascial release techniques, and neural tissue mobilization. Myofascial release techniques usually are very helpful in reducing the spasticity is there, so relaxing or releasing the facial restrictions that can be achieved. Neural tissue mobilizations usually preferred when we know it's neurogenic in origin and the neural tissue needs to be mobilized. Joint mobilization is also found to be helpful provided hypomobility is the reason, especially the hypomobility in the lumbar spine is the reason. Many a times this is so with the Parkinson's patient that they are very hypomobile, stroke patients. So the mobility is reduced and this hypomobility leads to low back pain, and it can be managed with joint mobilization techniques. So one should have expertise in it, and if you don't, so musculoskeletal physiotherapist, the patient can be referred to them. Then moving towards the electrotherapy, modalities like transcutaneous electrical nerve stimulation is found to be very effective in terms of if the pain is neurogenic in origin, nerve irritability is the cause. Then you have heat therapy, which will relax the tight muscle, ultrasound therapy to reduce the inflammation. Then is high intensity laser therapy, which reduces inflammation, muscle tightness, and even targeted the joint structure. So initially it was low intensity laser therapy. Now we are moving towards the high intensity laser therapy, and there are good evidences with high intensity laser therapy to deal with it. If tried and tested with the conservative management, if it works, or if it is not working much more towards it, then we have some neuro modulation techniques. Next slide, please. So which has transcranial magnetic stimulation, which is a non-invasive stimulation of specific brain areas to modulate pain perception and improve the motor function. Other one is spinal cord stimulation. This is not in the purview of physiotherapist. We need to refer the patient either to orthopedic surgeon or a neurophysician for this specific purpose, where it involves implanting a devices that delivers electrical impulses to the spinal cord to modulate the pain signals. And the recent development includes high frequency and burst stimulation that offers better pain relief for the patients with chronic low back pain, especially those with spinal cord injuries. Then you have some epidural injectables also available, or pain patches also available that can be dealt with the low back pain. Moving towards the exercise prescription that we can have. Already as mentioned, core is found to be a very strong reason, weak core is found to be a very strong reason for low back pain. So to stable core stabilization exercises, which will improve or give spinal support and reduce low back pain. We have pelvic tilting and bridging exercises, postural re-education, then spinal flexibility, lower limb strengthening, and managing the muscle tone and spasticity, for which we can have stretching, positioning, or Botox if required so, or surgical intervention. Next slide, please. So these are few examples of the core exercises as well as spinal flexibility exercises. And especially the major culprit for the low back pain becomes the gluteus weakness and quadriceps weakness, which affects the pelvic stability. So strengthening of those specific muscles becomes much more important in neurological patients. Next slide, please. So when we move towards the advanced exercise program, we have motor imagery or mirror therapy, which helps restore the normal movement patterns and reduce the low back pain. Then we have task-oriented training, where we can practice the functional activities in a controlled manner, and which reduces the compensatory movement and thus reduces the low back pain. Virtual reality, which has already been mentioned by Swati ma'am, cognitive behavioral therapy, mindfulness-based stress reduction, acceptance and commitment therapy. These are the newer techniques that can be used for managing the low back pain. Next slide, please. Robotic assisted rehabilitation, like robotic exoskeletons and robotic assisted gait trainings, that will help reduce the compensatory patterns and retain the normal movement pattern, and thus reduce the low back pain. Next slide, please. Next is postural and the ergonomic advice. Especially many patients who are wheelchair bound need to be trained about or educated about what are the correct postures, or use some assistive devices. So many cushions are available which has a back support, which helps pelvis to go into anterior pelvic tilt and thus reduce the stress on the back and reduce the low back pain. Next slide. Some assistive device which are already been mentioned by Swati ma'am, slide boards, gait belt, that can be used for transferring and moving in bed. Next slide. The wearable technologies for postural and movement monitoring, which are the newer ones and very effective one. We have smart variables like smart belts, insoles, postural corrective devices, which gives a constant feedback to the posture and gait and adjusts the movement to prevent compensatory patterns that leads to low back pain. And remote monitoring and AI-powered assessment tools are available so that the therapist or the physician or the personnels who are dealing with the low back pain can track their activity and track their compensatory movements or pressure areas, and thus make a tailorized program. Next slide. So these are the few examples of some wearable technologies for postural and movement monitoring. Next one. So patient education, where we are dealing with all this, pacing activities can be suggested to them, correct body mechanics ka use, avoiding activities that exacerbate their pain, plus multidisciplinary approach is the very much required thing, where we have already spoken about that we can have in the team neurologist, occupational therapist, pain specialist, and psychologist, and many more to it. Next slide. So that's all about it. And the take-home message is we need a multidisciplinary approach. When and where required, please do refer the patients for the specific things. And prevention is the key. So an ounce of prevention is worth a proud of cure. So that's what I would like to conclude my presentation. Thank you.
Yeah, thank you, Dr. Radha, for a very clear-cut explanation about the various physiotherapy approaches available and within physiotherapy, how the other specialists can help us in relieving the pain. And now to look at the interdisciplinary approach, wherein the medical fraternity is most important when we are talking about the patients with low back pain, specifically in patients with neurological dysfunction, because the impairment becomes double-fold with physical weakness, muscle weakness, and plus the pain. It is difficult to manage or improve the condition of the patients at times. So giving us the view about interdisciplinary approach of the low back pain, I invite Dr. Abhishek Srivastav sir for the session, for the talk. Dr. Srivastav sir.
Thank you, Savarna, for the kind invite. The slide visible?
Yes, sir.
Yeah. So as we already know, there's a big diagnostic triage in patients with low back pain. Patients can have a non-specific mechanical pain. They can have pain because of radiculopathy or spinal stenosis. Or third, other reason, which is because of some other issues affecting the spinal cords. So the first job is to identify what is causing this pain. The specific spinal causes are, as we know, tumor, infection, scotta equina, ankle spondylitis, spondyloarthropathy, compression fractures. First job is to identify these things should not be there when moving forward with conventional therapy. And patients also have a lot of abdominal issues like pancreatitis, nephrolithiasis, aortic aneurysms, sometimes endocarditis or pelvic pain, which also cause referred pain to the back and should be kept in mind in the DD while diagnosing these patients with purely specific spinal pain syndromes. Also, remember some red flags: possible fracture, tumor, infection, bladder bowel dysfunction, severe persisting deficit, or new weakness in LTL5 can also be a simple significance to causing of a new pathology in the back. Always keep in mind any appropriate referrals to treat these conditions. If you divide it into different by duration, it can be acute less than 6 weeks, subacute 6 to 12 weeks, chronic more than 12 weeks. Treatment differs as the duration of back pain increases with time. Also remember, low back pain has two components. One is a nociceptive component, it's local pathology of the disc, the facet, the muscle, the inflammation. And second is a neuropathic pathology, which is a nerve involvement, which is very common in such patient population. So always keep in mind We treat both neuropathic as well as the nociceptive pain in such patient population. Come to specific mechanical low back pain, it's very common. People can have tension, soreness, stiffness in muscles, and pain can be because of the joint, the disc, connective tissue, the muscle, or the nerve involvement. All can be source of this pain. See a simple study, 120 patients to identify the common reasons for back pain. 40% had facetal pain, which is very, very common. Commonly diagnosed as a disc prolapse and then treated accordingly, which is wrong. Only 1/4 have discogenic pain. 5% have sacroiliac joint pain. 13% have nerve root involvement, and 19% primarily has only muscle pain syndrome, not seen in the MRI or clinical correlation. Always remember, all pain in back is not because of disc. You have to identify the pain generator, treat it accordingly. For the principles of management in a multidisciplinary team, the goal is to alleviate pain, return to normal activities, and improve quality of life of a person with low back pain. You can manage it by non-pharmacological measures, pharmacological management, interventional pain management, or surgery. A full team is required: spine surgeons, neurologists, neurosurgeons, rehab physician, pain medicine, physical therapy, occupational therapy, psychology, yoga, social worker, orthotists, all can help in such patients with severe low back pain involvement. Basic principles of simple management. First is called as patient education and self-management. Always remember, we prescribe bed rest, and patients actually lie in bed for 3 weeks. The concept is always relative rest. They can carry out daily activities in the house. Don't keep them in bed for long, because the more motor power you lost by lying in bed is more than what back pain itself is causing. So remember, it's always relative rest, do daily activities in the house, and do it maximum 5 to 7 days, not 3 to 4 weeks. It's not recommended anywhere near the guidelines. Then start physical therapy. We have interventional modalities, IFT, TENS, ultrasound, and then start exercise programs. We always spoken about, always remember the difference in the flexion extension regimen as per the primary pathology, which is causing source of low back pain. And then ergonomics has to come a big role play. Occupational therapy comes into play, the ergonomics. We should know on current day of computer usage, how to put a monitor, how to take breaks in between. It's a good preventable measure in long-term care for low back pain. Yoga, for Indians like yoga. Remember, yoga has a pranayama concept, stretches and postures. All three are required in prevention and in long-term management of back pain. Psychology, simple steps to reduce stress. Because of stress, you can have more muscle spasm, which cause a lot of problems. So organize your life, communicate yourself, practice relaxation, simple stretches, take a break. Good preventive strategies to prevent as well as long-term back pain management. And those patients who have chronic back pain, low back pain, more than 6 months duration, need CBT, because as you know, our emotions and behavior influence our thought, and that affects our long-term outcome. CBT is a good role to play in chronic patients. Pharmacotherapy, always follow WHO pain related pattern. Step 1 is non-opioid medication. If pain worsens, add mild to moderate opioid plus adjuvants. If it's even severe, you add stronger opioids plus minus adjuvants. What are these medications? There's all simple protocol of called as step-related pattern for WHO. Non-opioid analgesics are commonly analgesics, anti-inflammatory medications, paracetamol, COX-2 inhibitors, toricoxib, very commonly celecoxib, or older ones like aspirin, ibuprofen, naproxen, diclofenac. They are good, but they can affect your kidney in long term, so be careful in long term usage. What you can add is a weaker opioid like tramadol and codeine, and if very severe pain, you can add morphine, oxycodone, fentanyl in such patients. Remember, these opioids are good medication for nociceptive pain, very partially effective for neuropathic pain. They work differently. So we have adjuvants like antidepressants, amitriptyline, nortriptyline, gabapentinoid, pregabalin, gabapentin, SSRI, duloxetine. These medications work well for the neuropathic component of pain. Treatment is different depending upon the cause, the reasons, the pain generation. Some patients are on physical therapy, are on yoga, have using belts, doing exercises, they're still not well. And they don't want surgery, they're not fit for surgery. What to do? It's called as interventional pain management. These are minimally invasive procedures which give permanent or long-term relief by stopping oxidative input or by correcting the neuropathy in such patients. It fills the gap between conservative management and the surgical procedure. Just take some case examples. You can do it with fluoroscopy guidance in the operation room, CT guidance in the radiology suite, or now in just daycare with ultrasound guidance. You can combine these modalities together depending upon the requirement. Just simple case, 34-year-old male, low backache, left lower limb radiation for few months, typical L5 dermatomal pattern, has paresthesia, numbness, has claudication, can walk up to 100 meters, can't go to office because of pain, is already on bed rest and exercises and analgesics, SLR is positive, have classical L5 symptoms of L5 radiculitis. See the MRI, classical L5 fetus collapse, compression of the nerve, not willing for surgery. We can do a simple L5 nerve root block with the ultrasound guidance, confirmed with fluoroscopy, simple daycare procedure. And you can say on immediate post-op, the pain is 0/10, SLR is now 80. On day one, pain is 1/10 NRS, started in physical therapy. At 1 month, NRS 2/10, can walk up to 1 kilometer, put on ergonomics, 6 months, NRS 2/10, can walk for more than a kilometer, was back to job at 1 month and started on yoga for his long-term care. So a multidisciplinary team can help together to help such patients to go back to their job. Another person, 54-year-old male, a driving professional, sitting job, on laptop for hours, poor ergonomics, the long-term pain in back for 2 years, can't do more than 15 minutes, can't run more than 15 minutes. We are stuck in between. Pain is more of stretching type, back more than the legs, with 7/10, and keeps on turning in the bed while sleeping. So remember, he has more pain in the back than in the legs. There's one clue. No signs of infection or inflammation. Flexion for the spine was normal. Extension was painful. Rotation was painful. The Faber fodder was negative. SLR was normal. No neurodeficits. See the MRI. It has L4, L5 in both levels of disc collapses, but not much of nerve compression. Quite clear, but bad facial arthropathy at last two levels. Clinical diagnosis, L5 essential arthropathy. He underwent a simple outpatient procedure of L5S1 physical injection intraarticular. Clearly see it going here. Small solution of mixture of locating agent and steroid. Immediately post procedure, no pain. Next day, he messages doc, I woke up without pain for ages. Thank you for that. 1 week post procedure, started physical therapy. He was free of pain at 4 weeks, started ergonomics, can stand, sit, and walk, go for longer walks, put in yoga for quality of life in long term. Now, the last case is 62-year-old male, was diagnosed as L5 vertebropathy outside. He came on a wheelchair actually, with no motor weakness, but severe pain in left leg, NRS 10/10, can't move the leg, can't straighten it, continuous sharp shooting type, left rotator region to knee and sometimes to the ankle, no radicular pattern, but good clue. But he was managed as a L5 disc collapse outside, was kept on bed rest for weeks, but no relief. See, spine ROM was normal, SLR non-testable, Faber was positive, Farder was positive outside. Bad tenderness in the gluteal region, in the piriformis muscle. Bad pain by pressing the piriformis muscle, or to flex the hip or knee, but no sensory motor deficits. Classical syndrome, if you can see, again the MRI was showing disc collapses with some nerve compression, but pain was not in radicular pattern. It's not radicular because L5 disc collapse. It's called as piriformis syndrome. He underwent ultrasound guided piriform muscle injection. Simple, you can just inject it in the piriformis in the outpatient, and can give you significant pain relief. Just to summarize, if you see acute patients for self-care, they will require patient education, in superficial heat. For physical therapy, they will require basic NSAIDs, muscle relaxants, sometimes short course of opioids. Non-pharmacological, they will require sometimes manipulation or exercise therapy. Versus subacute chronic pain, education is very important. Medication will change more towards TCAs, adjuvants, and opioids, but all these components of normal care are required: exercise, massage, acupuncture, yoga, CBT, relaxation to help such patients. What are indications for interventions in such patients? As an agent to conservative management, when it's not helping patient beyond 4 weeks, when they can't get surgery because of inoperable condition, comorbidities, if they have persistent post-operative pain after the surgery, when they can't take oral medications because of adverse effects, or they have adjacent level spinal fusion, can't undergo new surgery. So each thing has its own role to play in low back pain management. Just to summarize, it's very common, but remember it's a mixed pain syndrome, has both nociceptive as well as neurogenic component, affects quality of life. Intervention play good role in management, but multimodality, multidisciplinary care in the hour treat such patients. Thank you very much.
Thank you, Srivastava sir, for the explanation about the low back pain and the interdisciplinary approach that we have. So there is one question that has been asked, that is, what are the chances of recurrence of the symptoms after the surgery? Are there any chances, or what precautions should be taken that there is no recurrence?
The surgery is done for a specific cause. Surgery is done either for segmental instability, they put a fusion device. Surgery can be done just to release the nerve if the block is failing, to make the nerve free from compression. These are common two reasons for surgery. Now, most of the time when pain comes back after surgery, either because of a new site causing a problem, or something called as failed back syndrome. The patient thinks post-surgery, exercise is not required. No. Surgery also gives you a relief from a specific symptom. But to maintain the improvement and prevent other part of back not to interfere in long term, physical therapy and exercise are required for life to maintain the integrity of the back muscles.
Right. So exercises before and after surgery both are equally important in different forms. Thank you so much, sir. There is another question for physiotherapy experts. As we all know that physical inactivity and pain usually go hand in hand, and in patients with neurological dysfunction, with muscle weakness so much prevalent, the physical inactivity is always there. So how do we take care of both the things at the same time, physical inactivity and plus reducing the pain? Or what should be done first?
Ma'am, actually, bed rest worsen the low back pain.
Yeah,
Is it
you're audible. Yes, sir.
Yes. Bed rest worsen the low back pain. So with lumbar stabilization, we can provide the few at least we can start with the static exercises, then we can go depend on the patient's diagnosis and patient response. We can go for a dynamic stabilization exercises, which will be helpful for throughout the life of the patients.
Okay, so you mean to say right in the supine lying position, they can start with the exercises which can take care of the pain.
Bed exercises, we can start with the bed exercises. Right, then we can support your assistive exercises later on, depend on the patient's conditions. We can go for the active strategies.
Right. Thank you so much, Dr. Swati, for the explanation. I think there are no more questions. So we will wind up here. Dr. Srivastava sir,
Yeah, you can please
have any
summarize.
final concluding remarks?
I think we had a very wonderful discussion on different components of the low back pain management, including the causes, the evaluation, the non-pharmacological management approaches, pharmacological approaches, how a team can help such patients, which is the key in current era of evidence-based medicine. So I thank all the speakers, the chairs for their time on busy Sunday morning on Ganpati Day. I hope all of you will have good Ganpati Bappa Moria. All the best.
Thank you very much, sir. Thank you very much, ma'am. Thank you very much.
Thank you, everyone.
Thank you all participants for joining.
Thank you.
And thank you, IFNR, for giving us the opportunity. Thank you, sir.
Thank you.